Hello and welcome back to our channel. Today we are tackling a critically important topic in cardiology, tachyarrhythmias. We'll be breaking down the causes, the different types you'll encounter, and the essential treatment strategies for each. Let's start with the most common one, sinus tachycardia. First up is sinus tachycardia. This is a heart rhythm that originates, as the name suggests, from the sinoatrial or SA node. On an ECG, you'll see a heart rate greater than 100 beats per minute in an adult, but crucially, it maintains a normal P wave before every QRS complex, and the rhythm is regular. So, what causes the heart to speed up like this? The causes are often physiological or a response to an underlying issue: anxiety or stress, fever, anemia, heart failure, thyrotoxicosis, and the use of beta agonists like certain asthma medications. Typically, sinus tachycardia itself doesn't need treatment. The key is to find and treat the underlying cause. Atrial fibrillation. Next, we move to the most common pathological arrhythmia, atrial fibrillation, or AF. The classic description is an irregular rhythm with no discernible P waves on the ECG. AF can be classified based on its duration. Paroxysmal AF. This is AF that terminates on its own, usually within 7 days. Persistent AF. This type lasts longer than 7 days and is not self-terminating. It requires an electrical or pharmacological cardioversion to restore a normal rhythm. Permanent AF. This is when the patient and clinician have made a joint decision to no longer pursue a rhythm control strategy. The causes of AF are numerous and often related to structural heart issues: coronary artery disease, valvular heart disease, hypertension, sinoatrial disease, pericardial disease, cardiomyopathy, and non-cardiac causes like excess alcohol and thyrotoxicosis. Treatment for AF is a major topic, and it hinges on the decision between rate control and rhythm control. So when do we favor a rate control strategy? First, if the duration of the AF episode is more than 48 hours, if the patient is asymptomatic or has very minimal symptoms, in older patients, particularly those with multiple other health conditions, in patients with long-standing persistent AF. And finally, when a rhythm control strategy has already been tried and has failed. For these patients, we use medications like beta blockers or non-dihydropyridine calcium channel blockers such as diltiazem or verapamil. You can also add digoxin if needed. A quick but important note: avoid using calcium channel blockers in patients with heart failure, and be cautious with beta blockers in patients who have asthma. This brings us to the next logical question. When do we use a rhythm control strategy? When the AF duration is less than 48 hours. In patients with significant AF-related symptoms like palpitations, shortness of breath, or dizziness that are affecting their quality of life. In younger patients, generally those under 65 who are more active, and critically, in patients with heart failure where the AF is thought to be worsening their condition. Rhythm control can be achieved either electrically or with medication. If the patient is stable, you can use pharmacological cardioversion with IV amiodarone or flecainide, but remember, do not use flecainide in patients with structural heart disease. If the patient is unstable, you must use immediate electrical cardioversion. A patient is considered unstable if any of the following are present: shock, syncope, acute cardiac failure, or signs of myocardial ischemia like chest pain. And here is a golden note you must remember. Before performing an elective electrical cardioversion, the patient should ideally be on an anticoagulant for at least 3 to 4 weeks. If this isn't possible and you need to proceed, you must perform a transesophageal echo to rule out a thrombus in the left atrial appendage. After managing the acute AF episode, you must assess the patient's stroke risk using the CA2-DS2-VA score. If the score is 2 or more, the patient needs long-term anticoagulation, typically with a direct oral anticoagulant or DOAC, like apixaban. Let's quickly review the score. C for congestive heart failure gets 1 point. H for hypertension gets 1 point. A for age 75 or more gets 2 points. D for diabetes gets 1 point. S for a previous stroke or TIA gets 2 points. V for vascular disease gets 1 point. And the second A is for age between 65 to 74, which gets 1 point. Supraventricular tachycardia, SV. Moving on to SVT, this is a regular, narrow QRS tachycardia and you typically won't see any P waves. If the patient is stable, meaning no syncope, shock, acute heart failure, ischemia, you follow a stepwise approach. First, try vagal maneuvers. The modified Valsalva maneuver is highly effective. You can also try carotid sinus massage or inducing a gag reflex. If there's no response, the next step is adenosine. Give 6 mg IV push fast. If that doesn't work, give a 12 mg dose. Still no response? You can try a final 18 mg dose, but be careful, adenosine is contraindicated in asthmatic patients. Other drug options if adenosine fails or is contraindicated include calcium channel blockers like verapamil or diltiazem or beta blockers. Ventricular tachycardia, VT. Now for the wide complex tachycardias. Ventricular tachycardia, or VT, is a regular, wide QRS tachycardia with no P waves. The management depends entirely on stability. If the patient is stable, the treatment is amiodarone. If the patient is unstable, the treatment is an immediate synchronized DC shock. How can you be confident the rhythm is VT and not something else? Here are factors that strongly favor VT. A history of a previous myocardial infarction, MI. AV dissociation, which is pathognomonic. The presence of capture or fusion beats, also pathognomonic. An extreme left axis deviation, a very broad QRS complex, wider than 140 milliseconds. And finally, no response to carotid massage or adenosine. Polymorphic VT, torsade de pointe. Lastly, a special type of VT, polymorphic VT, also known as torsade de pointe. On the ECG, you'll see the QRS complexes appearing to twist around the isoelectric line. This is associated with a prolonged QT interval, and the immediate treatment is magnesium sulfate. And that is our summary of the most important tachycardias you need to know. Thank you for watching. If you want to see more videos like this, please subscribe to the channel and like the video. We'll see you in the next one.